Welcome to Airway Breathing Conversation, a podcast presented by the Anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Michael Dinsmore, an anesthesiologist at Toronto Western Hospital and University of Saskatchewan alumnus, discusses brain ultrasonography in the perioperative and critical care setting. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So this morning I'm going to talk a little bit about using ultrasound to look at brain anatomy and some function. Now, POCUS is kind of a buzzword these days, and for good reason. It's clinically very useful, especially for us anesthesiologists in the perioperative period. But when you hear about POCUS, mostly we're looking at POCUS for the heart, POCUS for the lung. We started doing a lot of gastric ultrasound, but rarely do they talk about POCUS of the brain. Okay, so today I kind of wanted to highlight two modalities, one being using transorbital ultrasonography for looking at the optic nerve sheath diameter, kind of as a surrogate for increased ICP. And the second modality that I want to highlight is using ultrasound to look at cerebral flow or cerebral hemodynamics. So the first one is going to be looking at optic nerve sheath diameter. So I just want to go over the basis of this technique, really delve into kind of how to use the ultrasound to get good imaging, how to interpret those images, some tips and some clinical pearls to help with your scanning. And then I want to end this section with how do we actually use this clinically, and how is this going to be useful for us as anesthesiologists? So the basic premise behind this is behind the orbit, you have the optic nerve here, and surrounding the optic nerve is cerebral spinal fluid. And this is in direct continuation with the cerebral spinal fluid in your head. And therefore, any increases in pressure, increase in ICP, are translated to the CSF around the optic nerve, and you actually see this start to expand. So the optic nerve itself, it doesn't change diameter at all, but this optic nerve sheath will start to expand as the CSF pressure increases. And this is actually what we're measuring, is the dura mater around the subarachnoid space. So when we talk about POCUS, often you've maybe heard this, that we're talking about the I-AIM framework. What this stands for is we really want to look at indications, why we're doing the scanning, acquisition, how do we get good imaging, how do we interpret this imaging, and then how do we make our measurements and decide on our clinical judgment from this. So this morning, I'm just going to switch this a little bit, and I'm going to start with the AIM, the acquisition, interpretation, measurement. And then at the end of this, we'll go through all of the clinical indications for this and what we can actually use it for. Okay, so to start with, what you basically need is a high-frequency linear probe. This has become pretty much standard in most of the ultrasound technology today. So the literature says anywhere greater than 7.5 megahertz. Now you're getting linear probes with 15, 19, 22. So the resolution, the image qualities of these are just getting better and better. On the new units, often you'll have an ophthalmic view. But if you don't, if you're still using one of the older systems, you can use nerve, or you can use small body parts, which we'll go into a little bit. You need a big tegaderm that you're going to put over the closed eyelid, and then you need copious amounts of gel. You're going to set your depth at about 4 centimeters, and then you can start your scanning. So obviously, anytime we do these scans, we always have to think of patient safety in ultrasound. And this is specifically the case in looking at the eye. The eye is a acoustically sensitive organ. So there's a theoretical risk of having thermal damage or mechanical damage if you keep the probe on too long on the eye, especially if you're using like color Doppler or something like that. This is all theoretical, but it's good to keep in the back of the head when you're using the ultrasound and we're setting up all the imaging. Okay, so if we look at thermal index, so what is thermal index? So It's basically just a rough estimate of how much that tissue is going to increase in temperature if we left the probe in a stationary position. So if we have a thermal index of 1, it suggests that the temperature is going to increase 1 degrees under these scanning conditions if we leave it there. And this is like if we leave it stationary for 5 to 10 minutes kind of thing. Okay, so the eye has low perfusion and poor heat dissipation. So even a small rise in this temperature is a concern. However, just to reiterate, this is all theoretical. There actually hasn't been any case studies of causing damage from this. Okay, so it's a very safe technique, but again, just keep this in the back of your mind. Same with mechanical injury. So obviously we're concerned about small microcavitations from the frequency and the oscillations of the sound waves, or the ultrasound waves, sorry. Again, as the MI increases, we have an increased likelihood of causing this. Because the eye has the vitreous fluid, it's like slightly high risk. So we want to keep the MI as low as possible as well. Okay, so if we look at an ultrasound machine, a few things we want to point out. We want to look at the bottom here. We want to make sure the ultrasound machine is set to high resolution. So we're using the highest frequency possible with our linear probe. Okay, so it's a resolution down here. We want to set the depth to around 4 centimeters. Next thing we want to look at is the setting, the transducer setting here. So this one is an older machine. This one's set at nerve with a high frequency of 15 megahertz. As you can see in the bottom here, the MI is 1.3 and the thermal index of tissue is set at 0.1. Which is okay. It's fine to go ahead. But on the newer machines here, you'll actually see small body parts with an MI of 0.9 and a TIS of 0.1. And even better now, we have this ophthalmic setting that shows an MI of 0.2 and a TIS of 0. Okay, so this is the safest. If you have this option, use it. Okay. The next thing is you have to find a volunteer or a good friend to let you practice on. This is where Graham comes in. So you want to make sure you put a big tegaderm across the closed eyelid. Make sure there's no micro bubbles or bubbles underneath because this will affect your imaging. And then you want to use a lot of gel because you don't want to put pressure on the patient's eye. It's a little bit uncomfortable if you're putting a lot of pressure, especially beginner ultrasonographers. If they don't anchor their hands, they're going to put a lot of pressure on the eyes. It's going to be uncomfortable for the patient. It won't cause any damage, but it's just uncomfortable. There's 2 ways to measure this. Okay, there's the transverse and there's the sagittal or longitudinal way. If you looked at some of the early evidence, they would recommend doing both of these, the transverse and the sagittal, because the eyeball and the optic nerve sheath diameter aren't quite a perfect circle. They're more elliptical. Okay, so you might get slightly different measurements. However, in the last decade, the sagittal has kind of gone out the window. It's been shown that they're very much almost equal, and it's very difficult to get a sagittal view. Sometimes the patient's orbit is sunken and you can't get the probe in there. So unless you have a small like hockey stick probe, it's very difficult to get this imaging. If you look at the transverse, this picture shows a little bit lower on the eyelid. I'd recommend actually going just above the eyelid in between the eyebrow and the eyelid to start and kind of pointing medial to start your scanning techniques. Okay, so when we put the probe on the eye, what do we actually see and what's our image going to show us? Okay, so here on the right, you can see, you'll start to see the eyelid at the most superior portion of your picture. Then you'll see the anterior chamber and posterior chamber. This is often demarcated with the lens. You may or may not see the lens. Often if you do see the lens, it's a good indication that you're kind of midline and you're going to have a good picture. You'll see the optic disc at the back, which is kind of between the hypoechoic and hyperechoic demarcation there. And then really what you're looking at is this hypoechoic line behind the orbit, and that's going to be your optic nerve and your optic nerve sheath diameter. And this is really what we want to look at the picture, this line going straight back. Okay. Now, when you have increased ICP, and you can see in the bottom here, you'll start to see this space increase, and that's what we're measuring. So 3 millimeters behind the optic disc, and then we're measuring across to measure the diameter of the change of that optic nerve sheath diameter. Okay, so with increased ICP, we hypothesize that this is going to increase and decrease with decreasing ICP. So initially, if we looked at, again, over the last decade with older ultrasound machines, this is often what we'd see. Just one straight line back. As long as they're perpendicular, you have a fairly good image. you measure 3 millimeters behind again, and then you're measuring this optic nerve sheath diameter across. So it was easy to kind of pick your sides because it was just the line between the hyperechoic and hypoechoic. Okay, but again, we weren't really certain where we were on the sheath. So you can imagine if you're scanning and catching just the edge side, it might be underestimated, and we're not sure for exactly in the middle. It was difficult to convince yourself of absolute perfect image. So now as the technology has gotten better, what you'll often see is this picture here on the right, okay? And now what you can see is actually a difference between the optic nerve itself and the optic nerve sheath diameter. So you'll see these kind of striated hyperechoic lines going down. And what that represents is most likely the subarachnoid material here. So you can see in the middle here on this picture, the hypoechoic, that's the optic nerve, the actual optic nerve, and this won't change in diameter. So therefore, if you look at each picture that you measure and actually take the optic nerve, it shouldn't change, and that will tell you if you're in the midline or not. Okay, so that should be around 3 millimeters as well, just like the distance behind the optic nerve. Okay, so the hyperechoic, the striated bands here, that's going to be your subarachnoid material. And then again, when it's hypoechoic here, these lines, that's going to be the dura mater. So that's going to be the inner and outer portion of this optic nerve sheath. Okay, and that's what you're measuring. That's what's going to expand and decrease with changes in CSF pressure. Okay, and then again, this material here, that's hyperechoic, that's going to be your retroorbital fat. Okay, so now with this better image, you can start to convince yourself and you can kind of repeat measurements that you're right in the middle and you're getting a good actual estimation of the optic nerve sheath. Okay. The other problem with doing these measurements is there's no defined protocol at the moment. So one of the things we're trying to do is actually develop a protocol. So all the measurements are going to be the same from researcher to researcher. Right now, people are measuring behind the optic nerve. So behind the retina at 1, and they're measuring 3 millimeters down from there. Some people are measuring at 2, which is basically the level of the lamina curbosa. And then some people are measuring kind of where it turns hypoechoic, and this is kind of the top of the optic nerve. So you can see it hopefully shouldn't theoretically change the optic nerve sheath diameter, even if you measured slightly at different depths behind. But at 3 millimeters, the reason we do 3 millimeters is because that's the greatest bang for your buck at that distance. So back 20 years ago, they did gelatin, they injected gelatin in cadaver studies. And even though you got direct proportional expansion with ICP at all the distances behind the nerve at 1, 3, 5, and 9, 3 was the most at 3. So if you can optimize this for a protocol, it's probably the best going forward. Okay, and the last thing when you're doing these measurements, okay, is the retinal artery and the vein actually run through the center of the nerve. And so if you can put Doppler on for a second and you can actually see this tracing going down the center of the nerve, again, you can convince yourself that you're right in the midline. You should see the nerve here. Again, shouldn't change in diameter. You see the subarachnoid material on the outside, and then the sheath, which you're measuring as a hypoechoic line here. Now, the reason this is important is when you start doing some of these measurements, you might end up with something that looks a little bit like this. So if you look at A, okay, you can kind of convince yourself there's 2 perpendicular lines going straight down the back of the picture there. And if you look at C, often before a lot of papers, they would actually measure this distance going straight down. Okay, this probably overestimates the size of the optic nerve sheath. And you can see why. If you look at B and you actually trace the retinal artery and vein, you can see how it starts to curve down the center of the line. So it's actually like curving off the page. And if you were to draw the lines of the actual a sheath curving like that, you'd actually have a more realistic view of what the optic nerve sheath is. And so if I get a picture like this, I try not to even measure this distance. I try to optimize my probe, my angulation, so that I actually get the optic artery and vein going down the center of the screen, perpendicular to those lines, which is going to be my optimal view. So something like this in picture D, that's kind of what I want to see in every picture. It's difficult to get a good image sometimes with the Doppler color in the back. So as long as I can get the Doppler, I can turn it off and then get my images there. Okay. So how easy is this to learn? How long is this going to take you? So if you read the literature, papers will say, up to 10 scans for the experienced ultrasonographer, and even as little as 25 for the novices. Now, this paper that quoted this, I don't exactly know. There isn't really much evidence to support where they got these numbers from. So I do like to highlight the second paper. And this was a single operator that measured the optic nerve sheath diameter in just 120 healthy volunteers over the course of a 6-month period. As you can see here, they did modeling, and around 21 patients, the user kind of reached a plateau where there was very little variance. So because they measured 4 times on each patient and took about 20 patients, they suggested about 80 scans, 80 individual scans before you become very proficient at this, which I would agree with. It's about in that ballpark. Now, one caveat to that being said, even with these first 20 patients, after 4 measurements repeated, the mean average of the optic nerve sheath diameter was still very, very good and within significant error. Okay, so the scanning is quite easy to learn. There's a few tricks and clinical pearls, but I think everyone can do it with a little bit of practice. It's very repeatable. Okay, so the inter-observer variability is roughly 0.2, 0.3. And the ICC values typically range above 0.9. So it's excellent agreement among trained observers. So the more and more people are doing this, it's becoming better and better, especially with ultrasound technology. The values are becoming more reproducible. Now, the best part of this technique I think, is the responsiveness of this technique. So it's very dynamic, and you can get almost instantaneous results from this. So what this group did, they had almost 20 patients, like 18 patients that had traumatic brain injury that came into the ICU. They were all intubated, and they had intrinsic ICP monitors in. So what they would do is they'd measure the ICP. Then as they were doing tracheal suction for the day, they would also measure the ICP. And then again, they'd measure the ICP again when the endotracheal suction was done. As you can see in the left diagram here, obviously the ICP here ranges anywhere from, kind of the 10, 12 all the way up to the high 20s. But during endotracheal suction, ICP obviously, increased. And then after the suction stopped, it went back down to kind of what the baseline of these patients were prior. So they did the exact same things while they were measuring optic nerve sheath diameter. And as you can see, same thing. As soon as they start the stimulation, the optic nerve sheath diameter increases, correlates with the ICP, and then goes back down almost instantly when they stop the endotracheal suction. So this is a dynamic process and almost changes, expands and decreases instantaneously. So now we can use this kind of as a dynamic measurement, and we can do repeat measurements to see how the progression of the patient is. Okay. Our group did something very, very similar just to show the response time for this. We used a RespiraRack system where we were able to change the patient's PaCO2, and we looked at optic nerve sheath diameter during these changes. As you can see, when the patient becomes hypercapnic and you have cerebral vasodilation, the optic nerve sheath increased. As soon as we put their PaC2 or end tidal CO2 back to baseline, it decreased to baseline. And again, it decreased a little bit during hypercapnia. That's to be expected because it can only decrease to a certain degree. It can expand to a much, much higher degree. Okay, so hopefully at this point, everyone's comfortable with kind of how they would set up the instrument, with the settings for the instrument, how to set up the patient, and what they're looking for when they're scanning and making the measurement. Okay. So now we have to ask yourself, why are we doing this and how useful it is in clinical practice? So probably the number one thing that you'll hear is that this is a surrogate of increased intracranial pressure. So most of the literature, the majority of the literature is this. Okay, but we're also going to talk about 3 other things, how we can use it for intracranial hypotension, ischemic strokes, and as a surrogate to help with the diagnosis of brain death and decreased LOC. So for increased ICP, there's multiple systematic reviews out about this process. The biggest issue I have with this technique is that there's no general consensus on the upper limit of optic nerve sheath diameter. Okay, and if you actually look at this, the reviews over the last kind of 10, 15 years, and you look at this column that says cutoff of optic nerve sheath diameter, ranges anywhere from 4.8 to, I think it's 6.4, which is a huge spread. Okay. And so I think the one caveat to take home if you start this using this technique in your clinical practice is a single measurement on a single patient isn't going to give you a ton of information. The real beauty of this technique is measuring the same patient ongoing to see either changes or to see how they change over time or after treatment or after diagnosis. That's where you're going to get it because each patient's so different. And so if you looked at like all the literature kind of previously, they used to say historically a cutoff of greater than 5 was a useful starting point for increased ICP. I would say 5 is kind of the upper limit of normal. So now with better quality data and better resolution, I'd say if you're looking around 5 to low 5s is kind of normal. But a cutoff above 5.7, 5.8, that's going to be your indication of increased ICP. So that correlates to kind of an ICP around 20 millimeters of mercury. Now, again, I just want to say again that it's important that you just don't measure one specific measurement and that's it. Okay, you really want to do this over a time range. I think that's important because some people can just have a big optic nerve, some people can have a small optic nerve. Okay, so you need the person as kind of their own baseline. All right, so one other thing that was very interesting was the use of this for spontaneous intracranial hypotension. Okay, so what they did here, they had 39 healthy patients, and then they had 39 patients with a diagnosis of spontaneous intracranial hypotension. Now, out of those 39 patients, you had 18 that were symptomatic. Okay, so they had orthostatic headache. They'd get an orthostatic headache when standing up. And you had 21 patients that still met the criteria for spontaneous intracranial hypotension, but they were asymptomatic and they didn't have a headache when standing. Okay, so what they did, they measured the optic nerve sheath diameter when the patient was supine and again when they were standing. Now, what they hypothesized with this is often these patients have a CSF leak. And so when they were laying down, the optic nerve sheath was increased. But when they stood up, because of the leak, it actually shrunk their optic nerve sheath diameter and they could see this. Okay, you can see that the data on the right is good data. Here they can see everything, the optic nerve, the subarachnoid material, and then the dura underneath. So it's a fairly reliable study. And what they showed here, if you can look at the black dots on the right, this was just the healthy and normal baseline patients. You can see with change in position, there was zero change in optic nerve sheath diameter, kind of as the median. If they compared this to the spontaneous intracranial hypotension group that were asymptomatic, so didn't have any headache, again, you saw no change in the red dots there. So it's very similar to baseline healthy patients. But very interestingly, the patients that had the headache, so they obviously had a CSF leak, when these patients stood up, you saw a decrease of almost just above 0.5 millimeters change in optic nerve sheath diameter from laying to standing. So here you can see how like in a clinic or in a spontaneous intracranial hypotension clinic, we can actually measure this. And this can be possibly used as a diagnosis criteria before they go for a CT myelogram or after they've had treatment to follow them to see if anything's changed in their optic nerve sheath diameter. Which is interesting because we can actually use this as a good segue into another paper that used this to monitor the success of an epidural blood patch. So although this study, I have to say, is only 10 subjects, has some issues with it, but the idea behind this is quite good. So they had 10 subjects that had a post-dural puncture headache. These 10 patients had epidural blood patch for treatment. And they measured the optic nerve sheath diameter before the epidural blood patch, and then again at 10 minutes, 2 hours, and then 20 hours after the epidural blood patch. And what you can see here in the green boxes, these are patients that they showed successful epidural blood patch. So they had no symptoms after the epidural blood patch, and you can see their optic nerve sheath diameter starts to increase as the time goes on. Okay, so from time 0 to time, so after the treatment, time 10 minutes and 2 hours, optic nerve sheath diameter is still increasing up to 20 hours. Now, the one patient, because this is a small sample size, the one patient that did not have success, so they continued to be symptomatic and show orthostatic headache, postural headache. You can see in the blue, it didn't really increase after the treatment. It went up slightly at the 2 hours, but then it went back down at the 20-hour mark, which means they probably continue to have a leak. So again, you can see how this technique can be useful potentially to reevaluate patients after after epidural blood patch or before we discharge them from hospital. This paper was just published. This was looking at outcomes for stroke. And so what they did here was patients that were admitted into hospital for potential stroke that didn't get a thrombectomy. They did the optic nerve sheath diameter when they were admitted and 2 days later. And they showed, depending on the change of size of that optic nerve sheath diameter, it was a predictor of how bad the outcomes were going to be. So for every 0.1 centimeter increase in optic nerve sheath diameter, your odds ratio of death were 4.2 among ischemic stroke and 6.2 among either ischemic or hemorrhagic stroke. So again, this can be used as maybe a predictor of what's going to happen to these patients in hospital and which ones we should keep in hospital or send for further treatment. Okay, and lastly, for the optic nerve sheath diameter, this can be used in the ICU as another adjunct to helping declare a patient brain dead. You'll see on the left here, the optic nerve sheath diameter is extremely high. You'll never see values like this, except if they've had severe brain injury and declared kind of brain dead. So 0.72. Anything above kind of that 0.65, 0.7 is extremely high. And this correlates to obviously very poor outcomes. You can see the control here is about 0.53 mean, which again is just on the upper limit of normal, as mentioned before. Now this group, the one group after them, took this even a little further, and they showed that you could actually use this even to differentiate between a comatose patient. So any patient that was in the hospital that wasn't declared, or an ICU that wasn't declared brain dead, but had a GCS of 3. So they're kind of in that comatose group. Again, huge values, almost 7 for the optic nerve sheath diameter. And the brain death group, again, was about 7.55, whereas you have a control group of about 5. Okay. Good. So you can kind of see some of the clinical indications that we're starting to use it for. And as time goes on, people are finding more and more uses for this clinically in bedside. One other caveat to this, I just want to mention, initially when we started doing this, patient position wasn't an issue. And the initial group showed that changes from supine to Trendelenburg and reverse Trendelenburg about 30 degrees really showed no difference or change in the optic nerve sheath diameter. However, as we're doing this more, we see more aggressive position changes, like from supine to standing, or this paper showed that that during radical prostatectomies, robotic prostatectomies, where they're in steep Trendelenburg, we actually do see changes over time. So this group showed increase of 0.6 millimeters during the radical robot-assisted prostatectomies. And again, this is something you can use in the OR to see kind of how the patient's cerebral pressures change after a 4 or 5 hour surgery in that position. Okay, so as mentioned at the start, the difficulty with starting to learn this technique is really trying to get the scans. You're either scanning patients in the ICU that are intubated and potentially have increased ICP, but just scanning healthy volunteers can become somewhat uncomfortable for the volunteer. We realized this when we started putting on workshops, and a volunteer, would have, 80 scans in a day on their eyes, switching kind of back and forth. It was pretty uncomfortable. Learners are often very heavy-handed and are putting a little bit more pressure on than needed. And so we really wanted to kind of develop something that you could use before trying to scan patients, just to get the angulation of your probe, how to measure it, and kind of get an idea of how much force to put on. So originally, I think when you saw those pictures of Graham, we were just designing this model, and we just used a pediatric cuff that we were able to inflate and deflate. We used half of a ping pong ball and kind of made our own jelly. And you could see here, you can see a nice globe or orbit, and behind it, we could increase the optic nerve sheath diameter kind of as a normal borderline increased, and then increased ICP kind of above the 6 millimeter mark. Okay, so this was great. We got some good feedback for this, but a lot of people said, this needs to be a little bit more realistic because the scanning actually is hard when you have the orbit in there and the eye and kind of the angulation. It's not just a flat surface. Okay, and then the other thing is they really were having difficulty with the force. So what we're in the process right now, we've taken this up a level. This is kind of our version 2. So we 3D printed an actual skull model, and we have the optic nerve and everything inside, kind of a ballistic gel. So it's can last kind of indefinitely. We're also putting a force sensor on the back of this. So when the learner puts their probe on, it'll give them a green light or red light if they're pressing too much force. This gives a little bit better indication of the angle to put the probe on, and again, to teach them the force. I feel like once they do this, they get comfortable, then they can go translate this into the actual clinical practice. It'll be a much smoother transition, and they'll be much more efficient at this and cause less injury or discomfort to the patient. So once I have this completely done, I will send you one for feedback. Okay, so we're just going to change topics here a little bit. We're going to talk about POCUS TCD in the clinical practice. I think more accurately, it should be called transcranial color-coded duplex because we actually get our picture. I used to do TCD when I first started with the TCD machines. I found it the learning curve was a little bit more difficult because you don't have the imaging to actually trace the cerebral vessels. I found it was kind of more of the blind in a dark room trying to listen for Doppler flows at certain gate depths. So I felt once I started using ultrasound, it's a much easier learning curve. It's much easier to get into transcranial Doppler and kind of have a foundation for going forward in this. Okay, so I'd like to touch on this a little bit this morning. Okay, so just to reiterate, this is a rule in. So it's only for a few things, okay? If we actually need to rule out some clinical diagnosis, you have to actually go to a formal TCD setting. Okay, so we're only gonna focus on this morning is the transtemporal window, and we're only gonna focus on the MCA. We're gonna talk about some of the indications that we can use this for, predominantly vasospasm, intracranial hypertension, so ICP, and cerebral circulatory arrest, and then as well identification of midline shift. As far as the ultrasound machine setup, we're going to use a phased array now. Hopefully, a lot of the new technology has transcranial setting. If it does, the index marker is going to be towards the frontal bone or orbit. If you do only have cardiac, that's fine. You can still use a fixed array. The actual index marker, though, is going to be facing to the occiput. Okay, we want to set a depth for this one around 14 to 17 centimeters. And the position, just somewhat that's whatever's comfortable. Okay, so although there's definitely different acoustic windows, we have the transorbital, the submandibular, transforaminal, and of course the transtemporal. We're just going to focus on this one. Okay, there's kind of the A and the P just means anterior, posterior, and medial. So a good way to set this up when you look at the patient is to kind of look at their external auditory meatus, then form a line to their outer canthus of the eye. Okay, and then you want to palpate the zygomatic arch, and you want to just go anterior there to the tragus. Okay, so that's a good starting point. And then you can change the probe depending on what you need. Okay, so when you actually put this, what you're scanning across and what you're looking for here, if you look across here, you're scanning right across the midbrain, so you're cutting up the hypothalamus. If you go just like 10 degrees angled up, you'll go into the diencephalon, and that you'll cross the thalamus and the third ventricle. So just have this in kind of mind when you're scanning and looking for the anatomy. Okay, and again, this shows the pictures. So if you have right across midbrain, which should be straight across in the blue there, you'll start to see the hyperechoic sphenoid bone. You'll start to see maybe the lesser wing of the sphenoid bone, and then you're looking for this kind of hypoechoic midbrain appearance in the center. Okay, and this is kind of going to be your landmark, and they call this the butterfly. Okay, if we angle this again, like I said, 10 degrees up, what you're really going to see is these hypoechoic thalamus, and you see this like equal sign in the middle, which is the borders of the third ventricle. Okay, so those are the two pictures you're kind of looking for when you're doing Doppler. So what I like to do is once I have the probe on, the first thing I do is when I set it to 14 centimeters depth, I look for this hyperechoic contralateral skull on the back. You can see the arrowheads pointing to the skull. Okay, so now I know I'm the proper depth. Next thing I do is I kind of scan across and I look for this butterfly appearance right in the middle. And often just above that and to the sides, you'll see a hyperechoic, and that's the sphenoid wing. And you're really looking for that butterfly appearance right here. Okay, so once I have that, then I know that I can probably turn on the color Doppler and start to look for my cerebral vasculature. Okay, so again, just a little bit of a refresher here. We're looking at the MCA. Okay, if you look at that circle of Willis, it's orientated lateral. Okay, so when we're shining the probe in like this, we're going to see a tracing here where our first one's going to be MCA. Then you should be able to see the ACA, the ACOM, and the PCA going around that kind of butterfly appearance. Okay, so if we look at the imaging here, you can actually see the nice circle of Willis wrapped around that butterfly. Okay, so your posterior P2, P1, then it goes into the MCA that's coming kind of into your probe, and then it goes into your anterior. Okay, so the nice part about this, which you don't have with the normal transcranial Doppler, is you can see this and you can optimize your picture and you can even trace it. So if I can just get that P2, I can start to trace P1 and go into the MCA. So I actually have a lot more information to guide me to find that MCA. Okay, so once I'm happy that I have MCA, which is usually at a gate depth of about 3.5 to 5.5 centimeters, it should be red because the blood is flowing towards the probe from my Nyquist plot. Okay, I can reduce the depth. I can put the Doppler over different parts of the MCA and look for max flow of the MCA, and then I should get a waveform something like this, where you have an upstroke systolic peak pressure, then you have the deaccelerating diastole again before you have the upstroke. What we're going to measure, what the machine's going to measure for you now, which is great, is you have the systolic peak velocity, which is the top of systole, and then you have the end diastolic velocity, and then it's going to calculate a mean velocity. You might see this, written differently as the time pointed average velocity or time average peak velocity, so TAV or TAP or mean velocity, all the same thing. Okay. It's going to calculate two indices for us. It's going to calculate the pulsatility index and the resistivity index. Okay, and I'll tell you why these are important a little bit later. But the machine will do this for you. If not, it's an easy formula. You can calculate if you can find the peak in the systolic and end diastolic and the mean. Okay. So again, this is on our ultrasound machine. So we're trying to find the MCA. Once we're kind of in the vicinity of the MCA, we do an auto trace. And here you just want to make sure the trace starts at the beginning of the systolic upstroke and it ends obviously at the end of the end diastolic just before any kind of upstroke. Okay, it'll calculate on the left here your time average peak velocity, which is your mean, which is the 52, and then your peak systolic, end diastolic, and it gives you an RI, PI. We can see the gate depth is around 4 to 5, like I said, depth wise. Okay, so we're pretty sure that we're on the MCA. We can do different parts of the MCA to see if this changes to get a max velocity. But once we have those numbers, okay, we can convince ourselves first it's the MCA. Okay, so these numbers correlate nicely with the averaged MCA. And then we can actually take these numbers and we can use the absolute number to tell us if the patient's having vasospasm. Okay. So we've looked at this a lot after, subarachnoid hemorrhage or after neurointerventional procedures or in the ICU, and a direct number will give us, normal mean blood flows 30 to 80, mild vasospasms about up to 120, moderate 120 to 200. Anything above 200, we can just say is severe vasospasm. And again, the cool thing about using this technique is we can give treatment or we can monitor the patient over time and see how this is changing, if it's getting worse or getting better with treatment. So it's a good modality for that. Now the issue is, if we're doing this in the ICU, there could be different cardiac output states, right? So is the patient, on pressors? Is the patient, hyperemic? There's different reasons we can have an increased blood flow. So what we have to do is calculate what's called the Lingard index. Okay, so if we're concerned the patient's having vasospasm, we put the TCD on, we get the absolute numbers. If it's less than 120, it's a low probability of spasm. If it's kind of this in between 120 to 200, we have to go one step further. If it's above 200, high probability of spasm. Okay, so it's this in between we're not sure of. So that's why we have to calculate a Lingard index. This is very, very easy to calculate. Okay, all we need is the extracranial blood flow of the ICA. Okay, so we can either measure this coming down with the submandibular view, and you might get, if you're measuring up here closer, you'll get a blue because it's going away from the probe, and you'll get the waveform underneath, or you can do the ICA. Once you have the ICA averaged peak velocity and the MCA peak velocity, it's just the ratio, and you'll get a number like 1.5. If we look at this, that's kind of normal. That was mine. If they're hyperemic, it's probably less than 3. If they're vasospastic, it's greater than 3. And again, the degree of vasospasms, depending on how high of a number you get. Okay, so that scanning is very easy to learn. It's very good kind of as a primer to get into this. Okay. Now, again, we can use this to look at increased ICP. So when you're looking at the MCA flow, you saw the waves before. You have a systolic upstroke, you're descending diastole, and you have that diastole is still above baseline with flow. Now, as you have increased ICP and the pressure, putting the pressure on these vessels, you start to see an upstroke, a higher upstroke in the systole, and you'll start to see this end diastole approaching 0 or closer to 0. Okay, and that means you're increasing your ICP. When you see these last two diagrams here on the right, when the actual ICP approaches the diastolic of 0, that's increased ICP, and then you actually might get this oscillating flow where it's like a backflow, and that goes, the diastole goes actually below baseline. Okay, when you start to see that, then you're worried about increased ICP, kind of approaching that 20 millimeters of mercury. Okay, so again, it's the, one measurement's great, but to actually to look at measurements, throughout the day or throughout hours to see how the patient's doing, if they're getting worse or better, it's a great way, non-invasive technique. I do have to say, 10% of people will not have a good acoustic window. So, try not to get too frustrated if you can't get good pictures, but most people, you're able to get decent pictures. Okay, so if you actually look at the spectrum of how this progresses over time with increased ICP, you can see a normal tracing in box A here. As you have reduced diastolic flow, kind of slowly approaching 0, just before you get the biphasic or oscillating flow. Once you have this is the beginning of cerebral circulatory arrest. Okay, as there's no real, the area under the curve of systole and diastole is almost equal to one another. And then you'll start to get these systolic spikes, which are very, very short spikes. They're under 50 centimeters per second of flow, and they last only like less than 200 milliseconds. And then you'll eventually get 0 flow. Now, the issue with this is it's difficult when you go and scan a patient and they have 0 flow. It's difficult to say anything or get anything from that because, one, we don't know if we're getting a good image or a bad image. So if we have 0 flow, we can't really say anything. So again, it's important to show these first steps for circulatory, cerebral circulatory arrest, where you see kind of an oscillating or backflow, then potentially we'll see the systolic spikes. And then once we have 0 flow, we can say confidently that this has progressed to 0 flow. If you just have 0 flow and you haven't seen any of these other things, you cannot say anything indefinitely, okay? Because you just don't know if your scanning technique is good enough. Okay, so again, these are just the 6 different phases that we identified in the process. I won't go over that again. Okay, and the last one that we looked at is a very easy way to do is midline shift. Okay, so this is, instead of using the midbrain, what you're going to do is see this diencephalic plane. Okay, so again, you want to see the contralateral skull. You want to make sure you see the midbrain, the sphenoid, and then you angulate the probe about 10 degrees up, and you'll start to see these hypoechoic thalamus and the equal sign, which correlates to the borders of the third ventricle. If you keep angulating this, you can see how the ventricle gets bigger or smaller. You want to do it at the size that the ventricle is the largest. Okay, and then you're basically just going to measure to that ventricle. So you can do this two ways. You can either do the Doppler on each side and measure to the ventricle. So you're comparing the left and the right. So something like this. So if you do on the right, you're measuring to that ventricle, and then you go on the left and you measure that ventricle. You compare them. Obviously, they should be equal if you have no midline shift. The other way you can do this is if you only have one window, or depending on the patient's positioning, or just for a quick scan, you can measure just the one side and kind of compare the ratio. Okay, so you do something like this, where you're measuring the top to the third ventricle and then the skull right at the demarcation between the bone and the hypoechoic portion to the ventricle, and then just do A minus B over 2. Obviously, they should be very close. If not, you have midline shift.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.